Dear students, in this video, we will learn why increased dead space volume of lung may cause or may lead to hypoxia. Now, what is hypoxia? That we know. Hypoxia is nothing but the oxygen deficiency at the level of tissues. So, in the closed circuit, our circulation, we know that blood is pumped by the heart and it is going to different peripheral tissues, and then it is again coming back to heart, and this deoxygenated blood is going to the lung for oxygenation. Okay, now the oxygen delivery to the tissues, it will depend upon not only on the respiratory system of the lung, it will also depend upon the cardiovascular system. Now oxygen delivery, it depends on the amount of oxygen entering into the lung, that is, and also the adequacy of the pulmonary gaseous exchange, how much oxygen is entering in the lung and how much is exchanged adequately and is coming to the blood. Then it will depend upon the blood flow to different tissues. So first is the adequacy of the exchange and the oxygen amount into the lung. Second point is the oxygen delivery, delivery of blood to the tissues or blood flow to the tissues. This will depend, this blood flow of individual tissue, it will depend upon the cardiac output, that is it will depend in so many factors related to cardiovascular system. Then it will depend upon the constriction of the blood vessels in the tissues, and it will also depend upon the oxygen carrying capacity of the blood, that is how much is the dissolved oxygen, how much hemoglobin is present in the blood so that it can be carried to the tissues, and lastly the affinity of the hemoglobin to the oxygen. All these factors will contribute how much oxygen will be delivered to the peripheral tissue. So the hypoxia will depend upon all these factors. Now, how this hypoxia develops if there is increased dead space volume? That is our point of interest. So, the main two reasons are for this hypoxia when the dead space volume is increased is the reduced alveolar ventilation, the first one. Second one is the availability of gaseous exchange surface of the lung, that is the diffusing surface area, it will also be reduced. So these are the two main factors responsible for less oxygen delivery to the tissues if the dead space volume is increased. Now we will explain them one by one. First is the reduced alveolar ventilation. So before going to this, we want to understand what is alveolar ventilation and what is the dead space. The conducting airways, we know that it begins from the trachea and branches dichotomously to greatly expand the surface area of the tissue in the lung. Okay, so this is the airways. So the first 16 generation of the airways, if you see this is the first 16 generation that includes the bronchi, bronchioles and the terminal bronchioles. It is known as the conducting zone. So this conducting airway actually it is made up of variety of specialized cells. Okay, so that provide more than simply a conduit of air to reach the lungs. Okay, but actually this portion, this conducting zone, it does not take place part in the gaseous exchange. It merely acts as a conduit or passage of the air. So we can divide these respiratory areas into two parts. One is the conducting zone, when there will be only passage of air and no exchange of gases. That is the first 16 generations up to the terminal bronchiole. Now beyond the terminal bronchiole, the last 7 generations form the transitional and respiratory zones where actually the gaseous exchange occurs. Okay, And it is made up of what? It is made up of respiratory bronchioles, alveolar duct and alveolar sac. Okay, so we can grossly divide the respiratory areas into two zones. One is the conducting zone, which does not take part into the gaseous exchange. It will act as a conduit or passage of air. And the last 7 generations, here is actually the gaseous exchange is taking place, which includes the respiratory bronchiole, alveolar duct and the alveolar sac. Now, because the gaseous exchange in the respiratory system occurs only at the terminal portions in the airways, the gas that occupies the rest of the respiratory system, that is into this conducting zone, this is not available for gaseous exchange with pulmonary capillary blood. Now, normally this volume in ml of is known as the dead space, which is also known as anatomical dead space, and it is approximately equal to the body weight in pounds. For example, if a man weighs 150 pound or 68 kg, so in that case, uh, if the tidal volume is 500 ml, then 150 ml will be the anatomical dead space out of this 500 tidal volume, and the rest 350, that is 500 minus 150, 350 ml will ultimately reach this exchange zone and will take part in the gaseous exchange. Okay, so this is about the dead space and anatomical dead space. So dead space is equal to, in normal healthy individual, this dead space is nothing but the anatomical dead space where there is no gaseous exchange. It is only acting as a conduit or passage of the airway. Now, in some disease conditions, we will see that the total dead space, it is not equal to anatomical dead space. In addition to that, there will be some kind of wasted ventilation. For example, if this anatomical dead space 150 ml is there, okay, so now the 350 ml is reaching into the exchange zone. In the exchange zone, if there is any defect, that in that case the ventilation that is entering into this defective part will be totally wasted. So that is known as the wasted ventilation, or also it is known as the physiological dead space. In that case, the total dead space will be equal to the anatomical dead space plus the amount that is wasted, that is the wasted ventilation or the physiological dead space. In this diagram, we can see the central part is the normal alveoli, where we can see the ventilation is okay, and also the perfusion into the pulmonary capillary, it is also okay. Okay, now in these alveoli, you can see that there is an obstruction. Why the ventilation is wasted? Why the anatomical dead space plus some physiological dead space is there? Because here you can see there is an obstruction. Although the blood flow through the pulmonary capillaries is okay, and the ventilation of this alveoli, it is zero. Okay, it is a kind of wasted ventilation. The air is entering, but it is not uh, going to the capillary. Okay, so this portion is wasted. Another type of wastage, it may be when the ventilation is okay, air is entering, there is no obstruction, but due to some pulmonary embolus, the blood flow through the capillaries, it is not happening. Okay, so although the oxygen is present and waiting to be getting exchanged, but as the blood flow is not there, so there will be no exchange. So in both the cases, there is wasted ventilation, so that they will be included into the physiological dead space. So in this person, the total dead space will be equal to anatomical dead space 150 ml plus the amount that is a physiological dead space or wasted ventilation. So we came to know about the exchange zone and the conductive zone, and from there we also came to know about the concept of dead space. Now we will try to understand about the alveolar ventilation, because the question was hypoxia. There will be hypoxia if the dead space volume is increased. Okay, so and we have uh, seen that the main cause of it is there will be reduction is alveolar ventilation that will cause the hypoxia if dead space is increased. So now we will try to understand what is alveolar ventilation. So before going to alveolar ventilation, we want to say a few words about the minute ventilation. So what is the definition of minute ventilation? The total volume of air entering and leaving the respiratory system in each minute. Okay, it is not differentiating between the exchange zone and the conducting zone. It is just telling that the total amount of air that is entering and leaving in the whole respiratory system in each minute. Okay, so here we can see that if the tidal volume in the resting state, the single breathing, that is how much amount of air is entering or coming out, that is the tidal volume. So tidal volume, and in 1 minute, what is the rate of the respiration? If we know these two things, that is the tidal volume and the respiratory rate. So for in one breath, if we take the tidal volume, and in 1 minute if we take say 10 times we are taking the breathing, so we can have the minute ventilation like tidal volume times the respiratory rate. So if the tidal volume is 500 ml, it is in the single breath resting state, it is going in and out this amount of air, and we are taking 12 breaths per minute. So in 1 minute, 500 into 12, that is around 6000 ml of air is entering and leaving the lung, that is the 6 liter per minute is your minute ventilation. Okay, so this is about the minute ventilation. Now we want to know about the alveolar ventilation. On the previous slide, we know that in 1 minute, say 6 liter of air it is coming in and out. Okay, so now uh, is this 6 liter, the whole amount of 6 liter is taking part into the gaseous exchange? No, we know that out of this 500 ml of tidal volume, 150 ml will remain confined within the exchange, within the conductive zone. It will not take part into the exchange. So how much is taking part into the actual exchange and delivery of oxygen to the tissues? This is the amount which is not inside this conduit or in the anatomical dead space. Okay, so we know that the total volume is equal to the it is the tidal volume is equal to the dead space volume plus the alveolar volume. Okay, now if we multiply all these things, that is tidal volume and the dead space volume and the alveolar volume into the respiratory rate n, so we will get this equation. So Vt into n, this means Ve and the dot above. Okay, so this means actually the exhaled minute volume. Okay, we can call it the exhaled minute volume. Now the dead space volume into the respiratory rate is known as the dead space ventilation, and the alveolar volume into the respiratory rate will be denoted as the alveolar ventilation. Okay, so Va is the alveolar ventilation per minute. Okay, so if we know the tidal volume, if we know the dead space volume, so we can easily derive how much air will take part into the gaseous exchange and what is the alveolar ventilation, that is in 1 minute how much of air will take part into the exchange. So it is clear that minute ventilation is equal to tidal volume into the respiratory rate, whereas alveolar ventilation, it is not the whole tidal volume, that is the tidal volume minus dead space into the respiratory rate is the alveolar ventilation. Okay, so we have came to know about the minute ventilation. From there we have derived this alveolar ventilation, that is the amount of air that is actually taking part into the gaseous exchange. Okay, now what happens if the dead space volume is increased? What will happen to this alveolar ventilation? So if there is decrease or increase in the dead space volume, that will affect the alveolar ventilation. How it will affect? So come to an example like this. We know that if the tidal volume, say it is 500 ml, okay, and the dead space volume, it is increased. Suppose the anatomical dead space is 150 and there are certain, due to some diseases, some wasted ventilation is also there. So the total value, it is coming to 250 ml. Now what will happen to this alveolar ventilation about the alveolar ventilation volume? So it will become, so VA will be 500 minus 250 is equal to 250. So normally we know that 500 ml is the tidal volume, dead space volume is 150. So the amount of air that is taking part into the ventilation, alveolar ventilation, is 350. So if the dead space volume is increased, then obviously there will be decrease in the alveolar ventilation. Okay. Or if we want to keep this alveolar ventilation constant, say I want to keep it uh, 375 or 350, in that case we have to increase the tidal volume. Okay, so here you can see that if the dead space volume, it is increased to 250 ml, okay, then, and in order to keep the alveolar ventilation constant, or alveolar volume of air constant, the tidal volume has to be increased to 625 ml instead of 500 ml. So from it, it is clear that if there is increase in the dead space volume, then the alveolar ventilation, or the volume of air that is actively taking part into the gaseous exchange and oxygen delivery, that volume will be reduced. So the first cause of hypoxia when there is increased dead space volume is obviously reduction in the alveolar ventilation. So the first point is explained. Now I want to highlight another important feature here. The variation of the respiratory rate and depth of alveolar ventilation, it will also affect our uh, gaseous exchange and oxygen delivery. Okay, suppose we can take two conditions. In one condition we have respiratory rate is high, so there is um, hyperventilation. The person is taking increased respiratory rate is there, and in another case the respiratory rate is less, yet the person is taking a deep breathing here. So in both the cases you can see the tidal volume here, it is 200 ml when the respiratory rate is high. When the respiratory rate is less, the tidal volume is 600 ml. In both the cases, the minute ventilation or minute volume is 6 liter. Okay, so minute ventilation is, it is 6 liter per minute. Okay, so but if we see the alveolar ventilation, okay, in alveolar ventilation we know that the tidal volume minus dead space into the respiratory rate, it is alveolar ventilation. If the person is taking a rapid breathing, the alveolar ventilation, that is only 1.5 liter or 1500 ml. But if the person is taking a deep breath, in that case it is becoming 4.5 liter. That is more amount of air is taking part into the oxygen gaseous exchange and more oxygen delivery. So the respiratory rate, type of respiration, whether it is a deep breathing or it is a shallow breathing, that will also affect the alveolar ventilation, although the minute volume will remain unaffected. So the first cause of hypoxia when there is increased dead space volume is the low alveolar ventilation. Second cause is the low surface area of diffusion. From our previous knowledge, we came to know that suppose these are all the alveoli present which are taking part into the gaseous exchange. Among them, these alveoli is ventilation is perfusion is okay, but here either the ventilation is defective or perfusion is defective. Here also some kind of defect is there. Here also, here also. So many alveoli they're having some defect. Okay, so that means we are having more wasted ventilation or more physiological dead space, and that the availability of the gaseous exchange surface, okay, along which the actual oxygen carbon dioxide transport or exchange or diffusion will take place, it is getting reduced. Okay, so the low surface area, if they are not performing well, all these alveoli, so the surface area available for the gaseous exchange, it is also reduced. That is also cause of less oxygen delivery to the blood and to the peripheral tissue, which will ultimately lead to hypoxia. So to summarize, when there is increased amount of dead space, there will be less oxygen delivery to the peripheral tissue or hypoxia. The first cause is there will be reduced alveolar ventilation, and second cause is the available surface along which the gaseous exchange will take place. This diffusing surface is also reduced. These are the two important causes of less oxygen delivery to the tissues when there is increased dead space volume. Some other causes are also responsible. So as there is less ventilation, so there will be retained carbon dioxide which can displace oxygen and which will further exacerbate the hypoxia, and impaired gaseous exchange. There, due to this, there will be reduced removal of CO2 and reduced uptake of oxygen. All of them will contribute to the peripheral less oxygen delivery or hypoxia. This is the reference, Gannon's textbook of physiology, chapter number 34.